It's Erin at Supercoder. Welcome, all you coding heroes out there. Today we're going to talk about correct coding for the evaluation and management services that physicians perform at nursing facilities. We're seeing signs that E&M claims for nursing home visits are going to be a big focus for auditors in the coming months. So we want to help you make double sure your practice is coding and documenting these visits correctly. Here's a number that'll make you wake up and take notice: 87%. That's the error rate for 99310 claims submitted to NGS, a Part B payer in 4 states. That means that only 13% of the 99310 claims submitted to NGS were actually correct. So you can hardly blame this MAC for announcing in late January that it will be doing a prepay edit for CPT code 99310. And as with all things Medicare, if one MAC sees an error rate like that, other MACs and other auditors, like RACs, will follow that path as well. And you can expect auditors to take a look at other nursing facility E&M codes too. Consultants who do audits tell us that errors for all nursing facility EM codes are high. So we turn to some recent Supercoder articles to remind ourselves of 4 things we always need to check when we submit nursing home EM claims. 1, check your physician's documentation, because a lot of them are under-documenting their nursing home visits. When doctors fail to document correctly, they raise the ghost of nursing home gang visits, a popular Medicare fraud scheme during the 1990s. Here's how the scheme worked. Unscrupulous physicians would simply walk through nursing home halls and later submit EM claims for patients they saw only briefly. Now we know the doctors you're working for are good guys and gals who are taking good care of nursing home residents. So make sure that's reflected in the documentation. For 99310, for example, documentation needs to have 2 of these 3 criteria: comprehensive interval history, comprehensive exam, and/or high complexity medical decision making. Point 2, if you're coding based on time, be sure to document the pertinent details. Ever since 2008, CPT has published average time spent on the nursing facility codes, allowing you to report them based on time. For physicians to bill these visits based on counseling and coordination of care time, the patient must be present during the visit, and the physician must document the amount of time spent in counseling. 3rd thing to check, 99318. Reserve that code for the annual assessment. Don't report code 99318 on the same date of service as a nursing facility services codes 99304 through 99316. So make sure you schedule the annual assessment on dates when no other assessments are necessary. That way you ensure that the patient receives the best service and that you can bill for all services rendered. Finally, point 4, don't forget to use the correct place of service code. Now this is tricky because one facility can have both skilled and non-skilled nursing beds, and that's going to affect which POS code you choose. So basically you choose POS code 31 when your doctor treats a patient who's in a skilled bed at the time of service. That means he's getting skilled nursing care, such as injections or ventilations. Choose POS 32 if a patient is not on Part A Medicare, but is instead on long-term care and is receiving medical, nursing, or rehabilitative services. POS code 33 is for facilities that provide patients with long-term personal assistance services. Patients are mobile in a custodial care facility, so there must be medical necessity for a doctor to see a patient at the facility and not in his office. Maybe a broken hip or something where the patient can't be transported. That's it for today's review of nursing facility EM coding. We hope you'll stop by Supercoder with all your coding questions so you can be your office's coding hero every day.